Some people say Oregon's healthcare system is in critical condition. Can the state afford to pay for expensive transplant surgery and still deliver other crucial services? At the center of the controversy is the issue of rationing health care.
You don't ration medical care unless you have to. When do you have to ration medical care? You have to ration medical care when you've run out of money.
Raisins that sing and dance, ice skating walruses, a pizza-destroying imp called, of all things, Annoyed. These and other abnormal creatures have sprung from a local film studio. Tonight, Front Street Weekly will take a look at the process called claymation.
Good evening and welcome to tonight's edition of Front Street Weekly. I'm Jim Swenson.
And I'm Gwyneth Gamble Booth. Our first story tonight focuses on an issue that has caused sharp controversy statewide and has made headlines around the country. The debate is about organ transplants, and for some people it's literally a life and death issue. It is a problem that involves ethics, economics, and as Jeff Schaefer explains, it is just one part of a much larger puzzle.
EKG, continuous readout.
Suppose you got sick, very sick, and had to go to the hospital for treatment.
And I'm going to give you some Pentothal now. You'll be asleep in just a minute.
Everyone hopes it will never happen, but if it did, would you be able to pay for that treatment? For thousands of people in Oregon, the answer is no. It's a bad situation that's been getting worse, but nobody seemed to notice until the legislature did something that grabbed everybody's attention.
Last year, here in Salem, the legislature decided not to fund certain types of transplant operations. In effect, the lawmakers drew a line on health care spending. But whenever you draw a line, someone will inevitably be the first one to cross it. What nobody could foresee in this case was that the first person to cross the line would be a little boy with leukemia.
7-year-old Kobe Howard needed a bone marrow transplant to have any hope of survival. But under the new guidelines, the state wouldn't pay for his operation. Kobe's family tried to raise the $100,000 needed for the surgery, but they didn't make it. Kobe died in December.
I said at that time that the legislature was doing something very stupid, that they were kidding themselves, that this wasn't going to backfire, that you couldn't allow these people just to die and not have some incredible amount of public concern and controversy.
State Representative Tom Mason has been a leader in the drive to get the transplant money restored. But he's run into strong opposition along the way, and a lot of that opposition has come from this man.
Now, if you recall, the social policy of the 1960s was universal health insurance coverage with Medicare and Medicaid. And the reason was that we didn't want to ration. We wanted to provide everything for everybody, and it's clear we can't afford to do that. So ultimately, you come back to trying to determine what that adequate level of care is.
John Kitzhaber is president of the Oregon State Senate, and he's also a physician. We tend to assume that doctors favor saving lives no matter what the cost. But Kitzhaber has insisted that spending decisions can't be made hastily every time there's a public outcry.
The fact that we make decisions that way and refuse to recognize limits is why we have a $3 trillion federal debt. It's why we owe $170 billion to foreign governments. It's why we have a $10 trillion unfunded liability between what we expect our kids to make and what we're planning to take out of their pockets to fund Social Security, Medicaid, and federal pension programs. Sooner or later, the wheels are going to fall off the wagon. And I think the sooner we recognize that we have limits and start making those hard decisions on a rational basis, not an emotional, political basis, the better off we're all going to be.
I would feel a lot more comfortable with this if the opponents of the transplant program needed transplants. It's a little bit like in a war where the general sitting back in the back of the lines is more than willing to send people out to do the dying for him. But the generals I want to see, the generals I respect, are the ones that are up front getting shot at. And no one making decisions here is getting shot at.
Kobe Howard's death set off a wave of headlines and a heated debate over how this state spends its health care dollars. But the controversy has also brought out the fact that a whole lot of people in Oregon aren't getting the health care they need. Up to now, most of the attention has continued to focus on the transplant patients because their problems are immediate and life-threatening. Kay Irwin of Portland had a rare form of cirrhosis, but liver transplants were not covered under the new state rules. Her son, Craig, has also been fighting to get the transplant money restored.
My life has turned into the point where it's like having two careers. A matter of fact, because of my involvement in the transplant issue, I have stepped down from a management position that I had with an insurance company and gone on to taking an agency position that will free up some of my time and give me the opportunity to spend more time on the transplant issue.
Then there's the case of Donna Arneson. She also needed a liver transplant, and at one point her son, Evan, appeared before the state's Legislative Emergency Board and pleaded for the restoration of the transplant money.
I just want you to say, Mama.
But at that January meeting, the Emergency Board wouldn't give in. Under the new rules, only transplants involving kidneys and corneas are possible candidates for state assistance. For anything else, including livers and bone marrow, the patients were on their own. For Kay Irwin, help came from California. A hospital in San Francisco heard about her case and agreed to do the surgery and then work out the payments later on. Donna Arneson benefited from a very effective fundraising campaign. Drew Davis is one of the people who ran the project, which was aimed at raising $140,000. And he acknowledges that such efforts have to be carefully managed and orchestrated.
So we needed a theme, and so the theme we came up with was Save My Mom.
How long did it take to raise the money after you began the Save My Mom aspect of the campaign?
To reach the $140,000, the magic point, it took us 3 weeks, which is really, you know, a condensed time period. And I think one of the ways we came about that, we got the post office to help by allowing people to send money to Save My Mom, Portland, Oregon. Don't have to remember address. Everything has to be simple. Everything has to be urgent.
The campaign worked so well that it raised $200,000, $60,000 more than necessary. Donna Arneson went to a Texas hospital, and on March 12th, she had a liver transplant. But while her fundraising was successful, Drew Davis admits that such campaigns can be very unpredictable.
There are campaigns that had started before us looking for money and are still in the process of trying to raise the money, and they're not even trying to raise the amount that we raised.
One of those other campaigns involves this little boy, David Holliday, who needs a bone marrow transplant. David's family lives in a small town near Medford, and so far they haven't been able to get any sustained fundraising drive going. And the whole idea of people asking for public donations to save their lives has been attacked as cruel and humiliating, and some of the severest critics are relatives of the patients themselves. How, they ask, can a state that spends hundreds of millions of dollars on health care not have some money set aside for these operations?
The question is how to allocate those limited dollars, and it seems to me that as a baseline, we should extend sound, basic health care services, including preventive care, to all Oregonians as a first order of business. And after that, look at the amount of money that is left and talk about how to allocate high-tech services.
When John Kitzhaber, or anyone, talks about allocating money and who's going to get it, the whole subject of health care can get very confusing just because there are so many numbers and statistics available. Here are just a few basic facts to show what's going on in Oregon right now. Medicaid is the federal program that accounts for a major portion of state health care spending. For each Medicaid dollar, the state contributes 38 cents and the federal government kicks in the remaining 62 cents. Now, during the current two-year budget schedule, the biennium, state officials estimate that Medicaid will account for about $300 million in medical assistance to the needy. Again, that's a combination of state and federal money. As to how many people will get that help, officials in the health division say about 140,000 Oregonians will qualify for some form of Medicaid. And here's another key piece of information. The original estimate for the transplant program was about $2.2 million, with about $800,000 coming from state funds. That was the figure that was eliminated from the budget last year. And again, that would have been for this current biennium. Planners figured that the amount would pay for about 34 transplant cases during the current two-year period. There have been a lot of arguments about these numbers and whether or not the transplant program would have been worth the expense. But it all comes back to the issue of rationing health care. And a lot of people are wondering if the state should be clamping limits on money that is supposed to help sick people get well.
When do you have to ration medical care? You have to ration medical care when you've run out of money. And when you have evaluated your other expenditures, when you've run out of money and you've evaluated your other expenditures. We have done neither in this state.
The reality is that we are currently rationing health care in this country, and to think that by funding one service or another service we can avoid rationing, I think, is to live in a dream world.
The different arguments are nothing new to Brian Hines. He's the director of Oregon Health Decisions, a nonprofit group that's been working for several years to make citizens more aware of health care issues. He cautions against focusing too narrowly on the transplant issue.
So I think, unfortunately, the debate is not going to proceed too far as long as we remain fixated on the organ transplants issue, because that's really just a window into a much bigger issue that affects hundreds of thousands of Oregonians who lack needed health care.
When Brian Hines talks about a window into a bigger issue, he's talking about something that healthcare workers have known about for quite a while.
So now they've told you to go home on bed, to bed rest? Yeah.
Mary Ann Curry has seen the problem firsthand. She's a nurse practitioner who volunteers one day a week in the Women's Free Clinic at Bologna Joe's. On this day, she's meeting with Cheryl, a young pregnant woman who is unemployed and living in a residence hotel in Portland.
Plus, I'm on the 3rd floor and there is no elevator.
Study after study has shown that for every dollar we spend on prenatal care, we save from $2 to $11 in immediate savings. That's just a savings that we can account for right after the baby's born.
Contrary to some reports, there was never an explicit decision made to cut transplant funds in favor of prenatal spending. But the prenatal issue is an extremely important part of the health care debate because, like transplants, the cost can be seen in both dollars and lives. Inadequate prenatal care can send a baby here to a neonatal intensive care unit where the cost of treatment is about $2,000 a day. State health officials hope that increasing prenatal services to the poor will produce healthier babies and minimize this kind of expensive treatment. This is where the spending questions get very tough. If we were to make a priority list for health care, would women like Cheryl go above or below transplant patients, or would they be equal? And if we decide certain groups are equal, how many of them can we jam onto the top of our priority list? This is the side of the issue that doesn't make headlines, but it's where we really confront the problem of who's going to get access to adequate health care. Julie Bratton is also a person who has a lot at stake in this controversy. She's an audiologist in Monmouth, near Salem. Her job involves testing people's hearing, so she knows the importance of good health care practices. Julie is also very aware of her own health because she has no insurance coverage. Her office is too small to offer a group plan, and she doesn't make enough money to pay for her own individual policy. She literally cannot afford to be sick.
The biggest thing is, what if I were to have appendicitis today and have to have it out? Where would the money come from to pay for that? Well, I'd have to sell something or try and get a loan or something like that because I just don't have the cash.
State officials say this is the real crisis in Oregon's healthcare system. They estimate that more than 400,000 people in this state have no insurance. And while many do qualify for Medicaid, there are about 250,000 people in Julie's situation.
I'm in limbo. I don't go to the doctor if I'm sick. That's basically, I try and treat myself if I can.
The state is worried about people like Julie, worried that many of them will wait until something is seriously wrong before they get medical help. The big question, of course, is how do we go about extending health care to such large numbers of people, and how do we decide what they'll get?
Yeah, this is an interesting chart.
Mike McCracken is spending a lot of time on those questions. He's the staff director of the Governor's Commission on Health Care, an 18-member panel that was appointed in February. The commission hopes to come up with criteria for allocating health care dollars and report back to the governor by September. But McCracken says that any solution to this whole debate will take a long time to work out.
I think the commission will probably recommend a plan that would take several biennia to accomplish. I'm hopeful that the governor will be able to select from the recommendations of the commission a doable agenda for the next legislative session.
But while all the talking goes on, what happens to the people who still need transplants? Well, that issue was partially resolved earlier this month when the State Emergency Board met again and accepted a compromise method of funding the operations. Here's how it will work. The state will accept a donation of $100,000 from the Kobe Howard Memorial Trust Fund and use that money to get additional Medicaid funds from the federal government. As long as the Kobe Howard Fund keeps funneling private donations to the state, the program will continue. But if the donations dry up, the program can be stopped again. The day after the compromise was reached, some of the people at the center of the controversy stopped by our studios to talk about what happened. Susan McGee is on the left here. She's Kobe Howard's aunt, along with Tammy Howard, Kobe's mother, and Craig Irwin. All of them agreed that the battle still isn't over.
The way the program is set up now, people are still funding this program. There's no general fund dollars, and I think it's very important that we get general fund dollars out of our state government for this.
What I find very discouraging is that you have a topic and an issue that affects people's lives, and it has boiled down to a lot of political maneuvering, and that political maneuvering has decided the policy here.
I mean, there's no reason why the state of Oregon can't do it. It's just that they're not willing to do it right now. What we need to do is get the members of the communities to change their minds, help us to change their minds, because we're obviously have reached the public. They're the ones that are supporting this.
For now, Susan, Tammy, and Craig will concentrate on raising more money for the Kobe Howard Trust Fund, so the compromise agreement won't run short of funds. And just about everyone seems to agree that health care spending will be a major topic of debate at the next legislative session.
And I think that the state will eventually begin funding transplant programs, but we need to fund them in the context of everything else that we're doing.
We need to open up the budget process. We need to get more participation by other legislators from all over the state in the Ways and Means process, in the budget process. So the legislators don't come out of the session having voted for things that they have no idea are contained within those budgets.
The decisions we have to make won't be easy. The transplant controversy is by no means the only flaw in our healthcare system. It's just the most glaring example at the moment, and there's no instant cure. But the solutions we come up with will tell us a lot about our values and ethics as a society, and whether or not those values are as healthy as they should be.
We have Kay Irwin. Good news came last week. She received a new liver early Friday morning and is now resting at Pacific Presbyterian Hospital in San Francisco. And David Holliday, the little boy who needs a bone marrow transplant, is no longer in Oregon. Last weekend, he and his family went to the Seattle area. They hope to establish residency in Washington and then have David's surgery paid for by that state. They say early talks with Washington health officials have been very encouraging.
Well, there are very few people these days who have not been exposed in one form or another to the work of Will Vinton.